Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today, I'm going to be talking about how you can tell the difference between a ventricular beat and a QRS with a bundle branch block. They're both wide QRS beats, which is abnormal. So let's go ahead and see how you can tell the difference. Coming right up. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today, we're going to be talking about how you can tell the difference between a bundle branch block and a wide QRS that is a result of a ventricular beat. Remember, wide, W in wide, goes with the W in weak. So a wide QRS equals a weak contraction. Remember, the QRS represents ventricular contraction. So if you have a wide QRS, you have a weak ventricular contraction, which decreases cardiac output. So we don't want our QRSs to be wide. So that's what I'm going to teach you the difference between. Probably not something you need to know for NCLEX if that's why you're watching this, but it is definitely applicable to clinical practice and it's super interesting. So let's go ahead and talk about that. I think you know that our YouTube channel is a part of the greater Clinic Review organization, where you can find our on-demand NCLEX reviews taught by the GOAT himself, Mark Klimek. We also do monthly small group tutoring. It comes in a bundle package. You get 4 tutorings a month, and then they're also recorded so you can watch them over and over again. And we also have a streaming service where you can watch all of our videos, particularly the ones here on YouTube. You can watch them with no commercials, and there's some additional videos on there as well that you won't find on YouTube. It's a small monthly fee, $20 a month. So let's go ahead and get started. So here's 2 different rhythms. These are the 2 different rhythms we're going to compare. The one on the top is a sinus rhythm with a bundle branch block. The one on the bottom is a ventricular tachycardia, and we're going to talk about how you can tell the difference between them. So first of all, if you look at the top rhythm, let me make this just a little bit bigger here for you. I don't know if that got any bigger or not. So if you look at the top rhythm, the arrows are pointing to the P waves, okay? And the P wave is upright and rounded. And there is a P wave for every QRS. Now, whenever you have an upright and rounded P wave, and there's one P wave for every QRS, you know that it must be a sinus rhythm, because that upright rounded P wave tells us that the electrical impulse is being initiated in the sinus node. Now, you may say, how can this be a sinus rhythm? That QRS looks weird. You're right. The QRS does look weird. But when we say it's a sinus rhythm, that means the rhythm is being controlled by the sinus node. The first word of any rhythm tells you what's controlling the rhythm. So a sinus rhythm is being controlled by the sinus node. An atrial rhythm is being controlled by someplace in the atria. A junctional rhythm is being controlled by the AV node, and a ventricular rhythm is being controlled by the ventricles. So when you say it's a sinus rhythm, all you're saying is that it's being controlled by the sinus node. And you know that when you have an upright and rounded P wave, okay? So it has to be a sinus rhythm. Now, if we look at this, sorry, it's sort of blurry, but it's fine. We know that each small box on this EKG paper is 0.04 seconds. I've talked about times in other videos, so I'm not going to spend a lot of time talking about that here, but you have to understand that the electrical impulse has to travel from the top of the heart to the bottom of the heart very, very quickly. And we know that has to happen because you have to have at minimum 60 beats in every minute. That's one contraction every second. And it has to get to the top of from the top of the heart to the bottom of the heart and then recover in under a second, y'all. So you know that this has to travel very fast. That's why we're looking at fractions of a second here. So each small box is 0.04 seconds, okay? And we know that the QRS should be 0.10 or less. So that should be 2.5 small boxes or less for a QRS. That tells you that it's a narrow QRS. Remember, a wide QRS is weak, so a narrow QRS is strong. So we're looking for it to be a narrow QRS, which means it's a strong contraction, which means it's giving us good cardiac output. So if we look at this one, we see it's 3 small boxes, which is 0.12. And you may say, well, that's not very wide. Yeah, it's not very wide, but it's still outside normal limits. And so we say to ourselves, well, why is that? Because if we have a strong contraction, it should not be outside normal limits, y'all. Okay. So what we know so far is that this is a sinus rhythm because it's got an upright and rounded P wave, but we have a wide QRS. So we're like, is that a weak contraction? What's going on here? Okay. So that's what we know so far. Now let's look at the one on the bottom. The one on the bottom has no P wave. Okay. That means it's not a sinus rhythm. If there's no P wave, it is not a sinus rhythm. In fact, if there's no P wave, it's not even an atrial rhythm. You have to have some kind of a P wave. It can be a fluttering P wave or a fluttering. Well, it's a P wave, yeah, because a upright rounded P wave is sinus. But if you have a fluttering P wave, it's atrial. If you have a fibrillating P wave, it's atrial fibrillation, right? But you have to have some kind of a P wave. Here we have zero P wave. So it's not a sinus rhythm. So let's look at this. If we look at the width of this QRS, it's actually 4 boxes, which is 0.16, not much wider than the other one, but it's still wide. So we have a wide QRS with no P wave. Now I want you to notice the R wave is going up. It doesn't really matter if it's going up, it's going in one direction, and the T wave is going in the opposite direction. So whenever you have a wide QRS where the R and the T are going in the opposite direction, it's always a ventricular beat, y'all. Always. A wide QRS where the R and the T are going in the opposite directions, it's always a ventricular beat. Now, the R could have been going down and the T could have been going up, and it still would have been a ventricular beat. It doesn't have to go up. It doesn't have to go down. They just have to go in the opposite directions. So if you want to do a little bit of your own investigation, you can Google PVCs, premature ventricular contractions, or just Google ventricular beats. You're going to see all kinds of pictures of ventricular beats. And what I want you to do is look at it and say, is this wide? Is it wider than 0.10? Is it wider than 2.5 boxes? And is the R going in the opposite direction of the T? If you do that, and you look at it, you're going to be able to recognize a premature ventricular contraction or any kind of ventricular contraction with absolutely no problem. So when we look at our bottom rhythm, we say there's no P wave, which means it's not a sinus rhythm. The QRS is wide, and the T or the R is going in the opposite direction of the T. So this has to be a ventricular rhythm. So our top rhythm is a sinus rhythm with a wide QRS. Our bottom one is a ventricular rhythm. Now, let me help you understand what happens with a bundle branch block. Okay. So you're going to have to suffer through my drawings here. I'm not an artiste, but I can do stick figures and straight lines and circles. All right. So we have our SA node at the top, our AV node in the middle. The electrical impulse has to travel from the SA node to the AV node. That's the top of the heart to the middle of the heart. And when that happens, you see your P and the line after it. Okay, so that gives you your PR interval from the beginning of the P to the beginning of the QRS. That's from the SA node to the AV node. Then it has to go from the AV node down the branches, bundle branches, and out into the Purkinje fibers. That gives you your QRS. And normally it goes up, it could go down, it could go up and down, but it's a pretty straight spike. It's a very pointy spike, okay? Now, what happens when you have a right bundle branch block? Remember, you have the bundle branches, the right and the left, and then going out into the Purkinje fibers. Well, let's say you have a block on the right side. And remember, the right ventricle is smaller physiologically than the left ventricle, okay? So the right ventricle is smaller, which means the right electrical conduction generates a smaller wave, so to speak, okay? But let's say you have a right bundle branch block. What you end up having is you have the left ventricle. It goes down the left side with no problem, and you see that upright spike there. But on the right side, it hits that block, and it has to go around it. That takes it longer. So then you see this second spike. So that's a right bundle branch block. And the reason the left, it's right is because the left is bigger physiologically, so the spike is taller than the right. Now, what if you have a left bundle branch block? You have a block there in the left side of the bundle branch. So you have the right side going down, no problem. And you have a spike there, a pointy spike. But then you have a second one because it takes longer to get around that block on the left side. And so you see a second spike, only it's taller than the first one. So that's a left bundle branch block. So here, if we go back to our original bundle branch block, we see the large first wave, which means the left ventricle contracts. And then we see a small second wave where the right ventricle then contracts. So what is this? This is a sinus rhythm with a right bundle branch block. That's what this top rhythm is. The bottom rhythm is actually a ventricular tachycardia. And you may say, well, why is it tachycardia? It doesn't look any faster than the one on the top. Okay. So I don't know if you want to know this or not, but the SA node, the sinus node, fires at a rate of 60 to 100. We have spare tires in our heart to take over if we lose our sinus node. Okay, it's like a spare tire. But just like a spare tire, you have to drive more slowly on a spare tire so it doesn't explode on you because they're not as good, right? Spare tires are never as good as the original tires. So if you look at your tire, it's going to say, don't go over 55 or something like that, right? So think of the same way. We have spare tires, but we don't go as fast. So the SA node fires at a rate of 60 to 100. The AV node is our spare tire. It can take over if the SA node is gone, but this only, the AV node only fires at a rate of 40 to 60. We have our last spare tire. Our very last spare tire is the ventricles. They can fire on their own, but they only fire at a rate of 20 to 40. So if you see someone who's in a ventricular rhythm at 35 beats per minute, that's actually a ventricular rhythm. That's their spare tire. Now they're not going to live for very long in that rhythm, but they usually are still alive at that point. If you see a ventricular rhythm at a rate of 35, they probably have a pulse. Okay. Now that doesn't mean they will have a pulse. You still got to check, but they probably do. If they have a ventricular rhythm at a rate of say 55 or 60, that's actually still considered a ventricular tachycardia, but they probably still have a pulse. Now, if you get a VTach going up to 120, 140, they probably don't have a pulse, y'all. What's the rate here? Well, this is a 6-second strip. So if you look at this, you can see, and let's count the QRSs. 1, 2, 3, 4, 5, 6, 7, 8. We have 8 QRSs in 6 seconds. So this is a rate of 80. So it's considered a ventricular tachycardia because remember the ventricles contract at a rate of 20 to 40. So we have a ventricular tachycardia, but I bet they have a pulse. Now, they might not. If they don't, you got to start CPR just like you would for anything else. But this is someone who I would think might have a pulse if you go check on them. Okay, let's go ahead and do some questions. I told you I thought it was unlikely you're going to get these on NCLEX, but we still can test your knowledge. Okay, so let's go ahead and test your knowledge. Patient presents with sustained ventricular tachycardia. What is the most appropriate action by the nurse if the patient is hemodynamically unstable? Which means their blood pressure is dropping. They probably still have a pulse. If they didn't have a pulse, they would say if they were pulseless. If they were pulseless, I'd have to start CPR. Okay. All right. So they come in, they're in VTach, sustained VTach. They have a pulse, but their blood pressure is dropping. They're probably lethargic, difficult to arouse, pale skin, and all that. Administer amiodarone, perform synchronized cardioversion, administer epinephrine, or defibrillate. We don't defibrillate if they have a pulse. We do synchronized cardioversion if they are unstable, but they have a pulse with VTach. A patient is diagnosed with a left bundle branch block on their ECG. Which of the following is a common clinical significance of left bundle branch block? So I will say we don't generally treat bundle branch blocks. If you see a bundle branch block, I mean, you have to go with whatever your doctors want, whatever the hospital policy is. I'm just telling you from my own personal experience. Generally, I don't call the doctor about bundle branch blocks. If it's a brand new bundle branch block, like yesterday they didn't have one and today they do, well, then I'm probably going to look to see what changed, what's going on, because that's a conduction problem. All of a sudden they didn't have a conduction problem. Now they do have a conduction problem, right? All of a sudden they have a block somewhere. They didn't have a block. What's the most common reason somebody gets a block? Honestly, it's either hypoxia, electrolyte imbalance, or in ischemia. Okay. Those are very common reasons somebody suddenly has an electrical change. So this is someone is diagnosed with a left bundle branch block. So this isn't me seeing suddenly they have a bundle branch block. This is their diagnosis. So, and we're not doing anything about it. So what should I think? Why do they have this? So let's think about it. Associated with heart failure, structural heart disease. I mean, it could be, those are heart conditions that can cause that. Hypoxia. I mean, you can have hypoxia with heart failure. You can have electrolyte imbalance with that. Often an incidental finding with no clinical significance. So just because we don't do anything about it doesn't mean it has no clinical significance. So I'm going to cross off B. Indicates an acute MI. The way this question is worded, it doesn't seem like it's a sudden change. And I don't want to say they're having an acute MI when they were diagnosed with a bundle branch block. That's not what I'm thinking. Always considered a life-threatening condition. No, it's not. Remember, I said we normally don't do anything about it. So in and of itself, a bundle branch block is not a life-threatening condition. So they're diagnosed with it. So if I say to myself, I wonder why they're having this, it's not because they're having an acute MI. It's because they probably have some structural heart problem or heart failure. That's the only answer that makes sense here. Remember, the right answer is the right answer because of the other answers. Now, if all of a sudden they developed a heart block, brand new heart block, never had a heart block before, I would be looking for ischemia or infarction. But this is a person who's been diagnosed with a bundle branch block. So I'm like, I wonder what could have caused that, right? All right, the nurse is reviewing the ECG of a patient experiencing PVCs. Which of the following descriptions best represents a PVC? An irregular shaped P wave? No. Ventricular beats are the QRSs. A prolonged PR interval? No. A narrow and normal QRS? No. A wide and bizarre QRS? Yes. That's kind of how it's described. PVCs are usually described as a wide and bizarre. Now, the reason it's called bizarre is because the R goes in the opposite direction of the T, which looks bizarre. Okay. So, but and so this is how they tend to describe it. But the wide, certainly you know why it's wide, it's weak. And then the R and the T go in the opposite direction, which makes it look bizarre. The nurse is caring for a patient with a right bundle branch block. What is the characteristic ECG finding of this? Prolonged PR? No. Widened QRS with a rabbit ear pattern? Yes. And V1 and V2? Sure. That's fine. But it's a rabbit ear. That's the common way it's described, rabbit ear. Narrowed QRS? No. ST segment depression? No. So it's a rabbit ears. And if you go back and look at the pictures, you'll see it looks like a rabbit ears. A patient has frequent PVCs on their ECG. The nurse knows that which electrolyte imbalance is commonly associated with this condition. So electrolyte imbalances are commonly associated with ventricular beats, PVCs, ventricular tachycardia, very common electrolyte imbalance. Out of all the electrolytes that we test, which one is the heart most sensitive to? It's the one you always guess. And you always guess it because it's always right as it relates to the heart. Okay. So that's why you watch for hypokalemia. Which of the following medications is most likely to be prescribed for a patient with recurrent episodes of VTAC? Recurrent episodes. DIG, amiodarone, atropine, adenosine. The frustrating thing about cardiac meds is they all start with an A. So DIG is out. DIG is when we want to strengthen the force of contraction or we want to control AFib. Okay, so that's what DIG is for. Amiodarone prevents ventricular tachycardia. Atropine speeds up the heart. Adenosine slows down the heart. So we want to prevent ventricular beats, which is amiodarone. The nurse notes a new onset left bundle branch block on a patient's ECG during a routine check. A new onset. Okay, now we have a new onset. What should the nurse prioritize in terms of further assessment? Prepare the patient for surgery? No. Perform immediate cardioversion? No. Cardioversion doesn't treat bundle branch block. Check for signs of MI, myocardial ischemia or infarction? Sure. Reassess the patient in an hour. I would rather look to see, because it's a brand new thing, right? So it's a brand new thing. So I'm like, I'm going to look for ischemia. Now, what else could I do? I could also look for electrolyte imbalance. I could look for hypoxia. Those would all be appropriate things. But remember, the right answer is the right answer because of the other answers. None of those other answers are here. This is the answer that's here that says, yeah, I'm going to look for ischemia. I'm going to look for hypoxia. I'm going to look for electrolyte imbalance. C is the right answer based on that. Now, if I have people say, well, what if it had electrolyte imbalance and ischemia? Then I'd say that's a really bad question, or it better be a SATA question. If it was a SATA question, I'd say pick them both. You can't choose between them. A nurse is caring for a patient with sustained VTAC who's alert and oriented with a stable blood pressure. What is the initial treatment the nurse anticipates? I told you VTAC, especially not if it's like 120, 140, but if it's say 60 to 80, VTAC can very likely have a pulse. So what are we going to do? Defibrillate? No, we defibrillate fibrillation. VFib. Administration of beta blockers? No, beta blockers slow heart rate, but it's not used for ventricular rhythms. Vagal maneuvers used for SVT. I talked about it in the SVT video I did last week, synchronized cardioversion. That's it. There you go, synchronized cardioversion. All right. Well, I do clinical with my students. And what I often do on Fridays when I go to get ready for a video on Friday, I think, what did I teach my students this week in clinical? What did they have questions about? And then if they had questions about it, sometimes I pick that. Like when I did my SVT video, I did that because I had a clinical question. I do a bundle branch blocks this Friday because this last week we had a bunch of patients with bundle branch blocks, and I was teaching my students about it. I knew they didn't know what it was, so I thought maybe all you don't know what it is either. So thank you for being a part of the Clinic Review family. Thank you for watching the video. Good luck in clinical practice if you're still watching me after you passed NCLEX. And if you're watching me before you pass NCLEX, good luck on your NCLEX. Thanks for watching. Bye.